My name is Maya McDaniel, and my project is titled Dying in Peace. This presentation will discuss how hospice and palliative care is used to ease one through the dying process, and how hospice and palliative care are administered in unconventional environments. When discussing the subject of end-of-life care, the first question that comes to mind is, what is palliative care, what is hospice, and what makes them different? Hospice care is a type of palliative care. The four major factors that help to determine whether a person is receiving palliative care or specifically hospice care are the place that the care is being administered, the time at which the treatment begins, payment options for the treatment, and what treatment options are available throughout the process. According to the Caregiver's Library, palliative care is usually administered at a hospital or other facility such as a nursing home, and it is administered when a patient receives a diagnosis of either a chronic or terminal illness. Insurance usually covers part of the cost because with a chronic illness, prescriptions can always change, and the sometimes intermittent doctor visits are usually billed separately, which can incur some extra costs. This brings up to treatment options in palliative care. With palliative care, though it is used to provide some comfort, it doesn't necessarily mean that the patient is dying, so life-prolonging treatment can be given if it's needed or wanted. If no more life-prolonging measures are available to the patient or wanted by the patient, then they are transferred to a hospice program. This is usually facilitated by the patient's primary physician, which is why it is so important that he or she has a trusting relationship with that physician. Hospice care is usually administered at a person's home, but can also be administered in a nursing home as well. It is administered within the last 6 months of a person's life, or if they're given a terminal illness diagnosis. Generally, it is covered by private insurance or Medicare, but that really depends on your plan. The treatment involves foregoing any further life-preserving treatments and giving the patient the opportunity to focus on the emotional aspects of dying. Now that I've discussed conventional hospice environments, let's discuss some non-conventional ones. For example, what happens if you're dying in prison? The article Dying in Prison, Providing Palliative Care in Challenging Environments by Bolger discusses this exact subject of providing comfort care in one of the most uncomfortable environments. For some inmates, if they are given 3 months or less to live, they are given compassionate release, where they are able to take advantage of the public's hospice resources. However, violent offenders do not have that option, so the prison is responsible for providing palliative care. Prison hospice began in the U.S. in the 1990s, following the AIDS epidemic. This is when the U.S. Prison Hospice Association was established. This association initiated the Guiding Responsive Grace for Corrections End of Life, or GRACE project, to give inmates an adequate option for end-of-life care. This program involves the innovative aspect of using inmate volunteers in addition to the medical staff. The rationale behind this is no one understands a prisoner like another prisoner. An interesting resource that I came across on the National Hospice and Palliative Care Organization has a compilation of inmate stories and their experience in this GRACE program. Prior to the inmate's experience, the hospital is just seen as the place of no return. But after the hospice was initiated, patients were able to receive round-the-clock visitors from the hospice volunteers as well as their loved ones. The program introduced a level of dignity to death that wasn't available to the prisoners in the past. The inmate puts it best when he says, "Never again, due to our hospice program, will another man unnecessarily die alone." So aside from alleviating the patient's physical pain, Palliative care programs supply the patient with a support system so that they can process their emotions surrounding their death. A great example of this is seen in the article Communication Behaviors in Patient and Caregiver Emotional Concerns, a description of home hospice communication by Clayton, Reblin, Carlisle, and Ellington. The purpose of the article was to find out what communication behaviors are used by hospice nurses when patients and their caregivers express concern or bring up issues surrounding the dying process. To analyze this situation, audio recordings from 7 patients accompanied by their caregivers and 5 hospice nurses were analyzed to determine what these nurses say when the conversation steers towards negative emotions surrounding death. These subjects can range anywhere from the physical pain they're going through or the psychological turmoil, the social, spiritual aspects of the dying process, or the structure of care that they should expect for the rest of their treatment. The patient is usually concerned more about the social, psychological, and spiritual aspect of the dying process, while the caregiver usually focuses more on what treatment options are available or the structure of the treatment plan. Throughout the 180 interview recordings, the most prevalent concern regarded the psychological aspects of the dying process. And the hospice nurses usually use specific communication behaviors, and these behaviors include positive emotion statements so that the patient and caregiver can let go of these concerns. And though the study had a relatively small sample group, it shows the importance of supporting the patient and their caregiver to help them through this difficult time. In addition to the medical staff, there are also other resources available to help patients through the emotional process of preparing for their death. A great example is the Heart and Soul program at the MJHS Hospice Center in New York. This program combines art therapy and music therapy to help the patients establish a legacy to leave to their loved ones, as well as give them an outlet to express the emotional pain that they are feeling when words fail them. Throughout the program, the patient may make physical artwork such as paintings or sculptures. They may also write songs for the loved ones or make playlists to leave behind. This process gives the patient some control over the legacy they leave behind, and it gives them a chance to reflect on their life and what impact they've had on their loved ones. Throughout this project, I learned just how much effort is put into making sure the patient is comfortable physically and emotionally, and that with the right amount of support, a patient can have a decent death in any environment, from prisons to their house to hospitals. The place certainly doesn't matter as much as the process.
Hold this heart when I go, sing my song when I go, sing it loud when I go, sing it proud when I go. Some people are learning to die, and some people are yearning to fly. Some people are learning to die, and some people are yearning to fly. Some people are learning to die, and some people are yearning to fly. But I know that I'll be yearning to fly. When my high, when my high, when my soul takes